Hello all. So a lot of people have asked for doing a small session on evaluation of post-operative knee joint, especially post-ACL reconstruction. So today's topic is MRI evaluation of post-anterior cruciate ligament reconstruction knee. We'll see normal maturation, quantification of the complications, and pitfalls in the diagnosis. So let us do it. So overall, if you see, the complication rate is around 10 to 25%, whatever you measure it as a minor complication or a major complication post ACL reconstruction. So the primary goal of MRI is to diagnose the mechanical instability and restricted range of movement. So instability is usually laxity, which is a clinical laxity, and restricted range of movement is stiffness. So what are the common types of grafts usually used is like a bone patellar tendon bone graft, which is a single thick strand graft. So that is a bone patellar tendon bone graft. So two ends there are bone and in between there is a patellar tendon. And other most commonly used graft, especially in India, is a four-strand graft, hamstring graft, double semitendinosus or gracilis graft. So it is a four-strand hamstring graft. So that is the other graft. And less commonly used is a synthetic or allograft. So these are the common grafts, which are types of grafts which are used in ACL reconstruction. So usual fixation is done with interference screws, whether it can be a bioabsorbable screw or a metallic screw, endo button, and transfixation pins. So these are the fixation devices. So interference screw, endo button, transfixation pins. So then what exactly what is a normal MR principles? What do you have? So the reconstructed ACL should follow the normal course and orientation of the native ACL. So it should usually the graft changes over time and making post-operative timing critical for interpretation. So we should know when exactly the graft was placed. Based on that, the graft signal, we can we can have the interpretation based on the timing of the how many months this the graft was placed. So and the post-op, how many months it is post-surgery. So the graft signal, we can uh, so the appearance of graft changes drastically over time. So we need to know how many months back the surgery was done. Based on that, we can say whether the graft signal which we are seeing now is a normal or an abnormal thing. So, like if you see 0 to 4 months, we'll have a variable intermediate signal, and 4 to 12 months we'll have increased signal intensity. After 12 to 24, usually it is a uniform low signal intensity. So these are the timelines which we need to remember. So why exactly this happens? Variable signal intensity because it is an early neovascularization, and why it is increased signal intensity because it is a peak time of neovascularization or revascularization. And why it is hypointense signal, uniform hypointense signal? Because it is a complete graft maturation. After complete graft maturation, it looks similar to the normal ligament. So it will have a low signal intensity on the all other sequences. So this is about that. What is the pitfall like when we are doing a, DSG graft, that is four-strand graft? The the there will be fluid signal we will be seeing in between these four strands. So that appears like increased signal intensity, but that is a gap between these 10 what do you say, graft fibers rather than 10. So, so normal finding due to four separate strands. Appearance must be parallel to the graft fibers. So we'll have this linear fluid signal intensity between these strands, which is a normal thing. So how and how my tibial tunnel should be, how my femoral tunnel should be. See this slide. So I'm going to the image. If you see, this is a post-ACL reconstruction knee joint, T2-weighted image. So if you see how should be my tibial tunnel? Tibial tunnel should be posterior to the line drawn for the intercondylar notch of the femur. Okay, so this is a tangent drawn along posterior aspect of the intercondylar notch of the femur. So if we see my tibial tunnel is posteriorly placed to this line which bifurcates the tibia. So this is a normal placement of the tibial tunnel. Okay. So what it says? So in sagittal view, the intra-articular opening should be positioned completely posterior to the line for the intercondylar roof. That is a Blumenstadt line. So in the sagittal view, the inferior tunnel margin should intersect the posterior femoral cortex line and intercondylar roof line. You see here, this is my intercondylar roof line, and this is the posterior cortex line, and this is the my femoral tunnel. Okay, this is the inferior margin of femoral tunnel, which is intersecting it. So this is a normal placement of the femoral graft. And also, if we draw a line posterior to the posterior cortex of the femur, the femoral tunnel should lie posterior to this. This is one more thing. So this is what is a normal placement of the tibial and femoral tunnels. So that is one thing. And other thing, if we see in the coronal image, if 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 it is my right knee, right? This is the right knee. So this femoral tunnel should be at least placed at 10 o'clock or 11 o'clock position. Okay, you see this is around 10 o'clock to 11 o'clock position. If it is a left knee, then it should be at least 1 o'clock or 1 o'clock or 2 o'clock position. So in the intercondylar notch level. So this is the normal positioning of the femoral tunnel on sagittal view and also coronal view. Then what are all the complications we should expect in a graft? So, usually graft complications, like laxity complications, like if you say it can be a graft tear or rupture. Okay. So, most common graft tear happens between 4 to 8 months time. So, in most common time for graft injury is 4 to 8 months and post surgery. Then we have graft stretching or insufficiency. There is intact graft, but if you see on MRI, there is an intact graft, but clinically there is laxity because of malposition of the tibial tunnel or femoral tunnel. So, what are the primary signs of graft tear? Direct sign is fiber discontinuity, that is complete loss of signal, or it can be an increased signal intensity, like focal increased signal intensity with few loss of few fibers. Okay, so fluid signal within the graft substance is highly specific for the tear. Okay, then graft morphology, whether there is thinning, irregularity, or increased waviness or laxity of the fibers. So these are the three primary signs. And what are the secondary signs or indirect signs of suggesting instability or insufficiency? When I drew an anterior drawer test. So MR anterior drawer sign. So what is anterior drawer sign? If you see this, yeah, I'm going to the lateral. Yeah, this is a lateral femoral condyle, lateral tibial condyle. Okay. So I need to draw a straight line. So I'm drawing a straight line here. So this straight line, if I'm placing posterior to the posterior margin of the femoral condyle, and I will copy this and paste it so that I get another line, same parallel line, and I am placing it posterior to the posterior margin of the lateral tibial condyle. The distance between two, if we measure, okay, this is 3.2 mm. Less than, okay, this is around clear 3.2 mm. So this is less than 5 mm, which is normal. Okay. So if you see, normal is less than 5, equivocal is 5 to 7, and more than 7 is a positive. So positive anterior MR anterior drawer sign. So MR anterior drawer sign, I have demonstrated the same on the image. So graft insufficiency or tear, we can say the graft insufficiency or tear when the MR anterior drawer sign is more than 7 mm. Okay. And associated signs like bone bruise, like because of pivot shift mechanism, we can have marrow edema in lateral femoral condyle, posterolateral tibial plateau. Okay, so which are highly suggestive of acute re-injury. Then meniscal coverage, uncovered posterior horn of lateral meniscus. So that is also our secondary sign of grafted tear. So this is about tear. So if we see, just now what we have seen. In this, our tibial tunnel is okay, femoral tunnel is okay, okay. But what is happening? Any abnormality in this? In this MRI, there is a marrow edema in medial femoral condyle. That looks more like an osteochondral injury. If you see, yeah, you can see this is an osteochondral injury. There is a breach in the cortex also, cartilage also here. So, and what is happening here is, if you see, there is some bright signal, not within the tendon, but within the tibial tunnel, adjacent to this ligament fibers. So, if you see on the T2, that bright signal we see, and on T1, so there is fluid signal intensity. Early signs of graft ganglion formation usually happens in the tibial tunnel. Okay. And what about this segment of the ligament? It shows almost intermediate to normal signal intensity. Okay. And T2 weighted images, if I see, even the femoral tunnel, the ligament appears normal in signal. So in this, we are able to see a small graft ganglion formation, early signs of graft ganglion formation. Yeah. So as we see, as we just saw, ACL tear, let us see the case. So this is the direct case as we direct evidence of see. So there is increased signal intensity, disruption of fibers in the mid substance of the anterior cruciate ligament graft. So this is a case of ACL graft tear. You can see almost near complete thickness tear. Most of the fibers are lost in its mid substance. If you see the femoral tunnel, looks good. Tibial tunnel looks good. Even if you are drawing a line along the posterior, along the intercondylar notch, the tibial tunnel is posterior to the line intersecting it on the tibia. So that is normally placed. Even the femoral tunnel is normally placed. If you see, there is a posterior cortex. I'm drawing a line along the posterior cortex. So this femoral tunnel is also posteriorly placed to this. Okay. And I'm seeing a coronal view, the right knee. The femoral tunnel is placed approximately 10 to 11 o'clock position only. So overall, that looks good. So yeah, this is about the ACL graft tear. So what is graft stretching and graft insufficiency? So graft stretching and insufficiency, so primarily the anterior femoral tunnel malpositioning is one of the cause. So subjecting the graft to undue stress and strain. So on flexion. So on what happens clinically, there will be persistent instability, laxity, despite of the intact graft. So MRI findings, what do you have is like we have the positive MR anterior drawer sign, posterior bowing of the graft on sagittal images. Okay, so intact, then the MR findings is intact fibers will be there. So only this chronic intermediate signal throughout the graft degenerative changes will be there due to repeated micro trauma. Okay, so this happens because of anterior femoral tunnel malposition. So femoral tunnel is malpositioned anteriorly. Okay, so that causes graft stretching and insufficiency. Then we have mucoid degeneration. So there can be mucoid degeneration as we see in the ACL, like ACL degeneration. A similar thing can also happen with the graft, where we have increased signal intensity of the graft, with maintained fibrillary pattern. So that is mucoid degeneration. So it can be differentiated from tear by there is no loss of fibers in the mucoid degeneration. And there is something called graft ganglion formation or cystic degeneration, as I have shown you in the previous thing, where there is early signs of graft ganglion formation is there. I'll show you one more case. So in this case, I wanted to show you, see the ACL, it is wavy, okay? The anterior cruciate ligament graft is wavy. So that indicates there is some graft tear. So if I'm going towards the femoral tunnel, posteriorly, you find this T2 PDFS hyperintense signal. So the graft is also showing degeneration, mucoid degeneration, and also we have a small cystic degeneration along the posterior fibers of the femoral half of the ACL graft. Okay, so this is a cystic degeneration. What you are seeing this? Okay, done. So yeah. So what are the technical complications because of tunnel placement and isometry? So it can be a mechanical impingement. So graft impingement can happen, or increased strain, that is stretching, can happen. So what happens in mechanical impingement? This is because of what exactly it is because of? So tunnel malpositioning. So because of the tunnel is not correctly positioned, the graft can go either into strain, that is tension, or stretching, make or stiffness. So that which happens. So because of that, there is abnormal stretch. There is difficulty in extension of the knee joint, and also tunnel widening. So what is this anterior tibial tunnel malpositioning? So what is happening? The anterior tibial tunnel usually the tibial tunnel should be placed posterior to the line drawn further, or the Blumen's line. So posteriorly placed to the Blumen's line. But if it is placed anteriorly, what happens? Tibial tunnel is extremely anteriorly placed. So the graft continuously gets rubbed over the roof of the intercondylar notch in extension. So what happens there? Intra-articular if you see an MRI, we'll see that tibial panel is placed anteriorly, one thing. Then there is increased signal intensity, fraying, and partial tear at the site of impingement, that is at the femoral half. So if it is detected early, then we do to do notchoplasty, that is arthroscopic resection of the notch roof. So that is one more thing. And what anterior femoral malpositioning. So this causes what? Graft stretching and instability. So as we have seen previously also, the femoral tunnel is anteriorly placed. So that causes graft to become tight in flexion. So causing chronic strain, stretching, failure of this function. So, so in an MRI, what happens? Tunnel lies anterior to the intersecting point defined with the posterior cortex line and intercondylar roof line. So, what is the consequence? Is increased risk of graft insufficiency and stretching. There is one more thing called lateral tunnel malpositioning. That is what is like the tibial tunnel is more laterally placed. So usually far laterally placed. That also can cause impingement. So graft impingement can happen. One more thing is a late onset complication called known as tunnel widening. So what happens in tunnel widening? There is progressive enlargement of femoral and tibial tunnels. If we normally measure even on CT, okay, on CT, the tibial tunnel and femoral tunnel doesn't measure more than 10 mm. If you see this width is around 10 mm. If it is more than 14 mm, that is tunnel widening. So tunnel widening is described as diameter more than 14 mm. So that requires revision procedures. Okay. This causes what? Cystic degeneration of graft or retraction of the bioabsorbable screws. One more, one of the dangerous complications post ACL reconstruction is arthrofibrosis. So what happens in arthrofibrosis? Abnormal proliferation of fibrous tissue triggered by trauma or surgery, resulting in unchecked inflammatory healing response. So because of this unchecked healing response, there is a lot of fibrous tissue burden within the joint. So usually ACL reconstruction, which is performed less than 4 weeks post injury, okay, or associated other ligament injuries or poor pre-operative range of movement. These are risk factors for developing arthrofibrosis. So arthrofibrosis again two types. It can be a localized lesion, which is a cyclops lesion. Most of you have been have seen it in spotters, where you can see a T2 T1 hypointense signal lesion just anterior to the tibial tunnel, just adjacent to the graft without associated graft tear. That is a cyclops lesion. So this is a cyclops lesion. So it is found around 25% in ACL reconstruction at 6 months, but 2% are only symptomatic. So so that is cyclops lesion. So if the cyclops lesion is more than 1 centimeter, MRI accuracy is more than 90% in detecting the lesions. Okay. What is pseudocyclops lesion? Because of graft tear at tibial tunnel, these fibers are torn and appears to be forming a nodular mass and mimic a cyclops lesion. But how can you decide say whether it is a cyclops lesion or pseudocyclops lesion? If there is no partial graft tear, that should be a cyclops lesion. If there is a partial graft tear and these fibers are spilling anteriorly and mimicking that, that is a pseudocyclops lesion. There is another entity called diffuse arthrofibrosis and anterior interval fibrosis. So this is generalized scarring. This fibrous tissue encases ACL graft, extends anteriorly and posterior joint recess. So anterior interval fibrosis is scarring over the posterior aspect of the infrapatellar pad, bridging the interval from the patella to tibia. So what happens in this, in a chronic stage, because of this anterior interval fibrosis, there can be a patella baja or patella infera. So because of this extensive fibrosis, the patella retracts and gets pulled down. So if I show you a case here, let us see. Yeah, this is yeah, T2 weighted image. If you see, there is degeneration of graft as we discussed previously. Okay, if you see this infrapatellar fat pad, POFAS fat pad is all scarred, fibrotic. From where it is starting? Is starting from the anterior aspect of the ACL graft and tibial tunnel. So from here, it is extending anteriorly and causing fibrosis. Okay, that is the anterior interval fibrosis. It's a diffuse form of arthrofibrosis. One more entity, like it's not a focal lesion. Like if you are seeing only this thing, this T2 hypointense signal, just anterior to the ACL graft in the tibial tunnel, then it is an cyclops lesion. But here, if we see, we are not only seeing that hypointense signal here, but also that is extending and causing extensive scarring of the anterior interval. So this is anterior interval fibrosis. In diffuse arthrofibrosis, even posterior joint capsule and posterior lateral, medial, everything will be extensively involved. So that is the thing. Next, as we have seen previously, there is a graft degeneration, like cystic degeneration or a graft ganglion formation. And other hardware complications, what you have is like uh, interference screw fracture, migration, bone plug fracture or displacement, endo button migration. Usually, all these things can be detected on your plain radiograph or a CT. So, What is the role of MRI? It is very critical for bioabsorbable screws, especially. So, which are difficult to be seen on a plain film. And for detecting secondary injuries from aggression of metallic hardware. So, that is the thing. So, direct visualization of this hardware outside the tunnel or fragmented within the joint. So, especially for the bioabsorbable screws. Okay. Other complication is septic arthritis, which is rare but critical. We know what happens in septic arthritis, like joint effusion, synovial thickening, figure and contrast. That is show enhancement. There is paroedema. There is diffuse adjacent soft tissue edema. So that's the thing. Other miscellaneous complications: intraocular loose bodies, chondral injuries like osteochondral lesions, or cartilaginous or bony fragments, or vascular complications. Very rare because of this surgery, post-surgical. The pseudoaneurysm of the inferior geniculate artery has been reported. Okay. So what is the checklist now? So this is our checklist, which is important. So what are all the things I need to check in post ACL reconstruction? One is graft integrity. So to look for the signal, and we need to know it is how many months post surgery. Based on that, if there is less than 4 months or 4 to 12 months, or whether it is more than uh, 12 to 14, 12 to 24 months. So based on that, we can decide uniformity. Then integrity, one is signal, other thing is discontinuity or increased signal intensity on T2-weighted images, as we have seen. Then tibial tunnel position, posterior to the line drawn for the Bluesman sat line. So what is the key here, or what we need to look for? If there is any roof impingement, how we know anterior placement of the tibial tunnel? So if tibial tunnel is anteriorly placed to the Blumen satellite, then we can expect roof impingement. Then femoral tunnel, if in correct isometry, whether it is at 10 o'clock to 11 o'clock position, if it is a right knee, and at 1 o'clock to 2 o'clock position, if it is in left knee. If it is anteriorly placed, then stretching or insufficiency can happen. So then range of motion, smooth, unimpeded course. So restricted range of motion is there. Then what we have to look for? Cyclops lesion and diffuse arthrofibrosis. Then tunnel bone. So the bony tunnel is showing sclerotic margins or not. That's okay. But what is abnormal finding? Widening of tunnel. That is more than 14 mm. And edema, marrow edema surrounding the tunnel. So there's some inflammation or infection. Soft tissues. Normal infrapatellar fat pad. Or whether there's any patella baja because of extensive fibrosis, ganglion cyst formation, or effusions. These are the things. This is the checklist in post ACL reconstruction MRI. This table, if you can remember, then most of the things will be done. One more table I want to show. Is a summary table. So if there is an instability or acute re-injury, what is my primary diagnosis? Is a graft tear. If there is an acute re-injury or an instability, usually what you should expect is a graft tear. So how do you quantify? What is the feature? Is a positive MR anterior drawer sign, which is more than 7 mm. If you have a chronic laxity, that is graft stretching. What happens in chronic graft stretching? There will be posterior bowing of the ACL graft and diffuse increased signal intensity with intact graft. So that is in the case of chronic laxity. And when there is loss of extension, what you should expect? There is restricted moment of stiffness. So cyclops lesion. So there's focal nodular mass anterior to the graft. So the chronic motion loss, if there is a chronic motion loss, then we should expect arthrofibrosis or anterior interval fibrosis causing patella baja. So diffuse increased signal, scarring, and patellar position change. So these are the things in chronic motion loss. If there is pain and palpable mass, then any gaff ganglion formation, we need to look at. So this is what. So what we have to see, one is time matters. Imaging pearl is a time matters that judge the graft signal based on post-operative time. Hamstring versus a patellar bone tendon bone graft. Usually we have linear T2 signal in DSG graft is normal. So which is abnormal in patellar graft. So look laterally, like if there is an look for an MR anterior drawer sign. Okay. And beware of impingement, like persistent signal changes beyond 1 year may indicate chronic mechanical stress, even without a complete tear. So these are the things we need to remember in post ACL reconstruction MRI. Okay, I've shown you this case. This case, yeah. Let us see this case and close. This is also post ACL reconstruction. If I see grossly the femoral tunnel appears normal, the tibial tunnel appears normal, but how is the ligament? It is almost like completely torn, completely retracted. So if you see, this is a tibial tunnel. Is it normal or abnormal? It's normal only. This tibial tunnel is normal only. If you see that graft, yeah, is attached with strings onto this endo button here. See? These are the strings attached to the endo button here. That is okay. But what is happening inside this tibial tunnel is there is cystic changes, graft ganglion formation. See, it is 12. And if we see here, this cystic changes, this is cystic degeneration of the femoral half of the graft. Okay. So almost this ACL graft is completely torn. There are other pathologies also in this. If you see, there is a bucket handle tear associated. Medial meniscus bucket handle tear is there. It is almost a full thickness graft tear with graft ganglion formation or cystic degeneration of the graft. Okay. Thank you.